We shall start now. Can you answer this question, guys? Easy, right? So let me tell you something. Most often they will give a simple, straightforward questions from orthopedics in NEET examination. Unlike your INI CET, usually it will be a straightforward questions. Okay. What I want you to know is, will beg an answer from you. 8-year female child. By this word, what is the thing that they are trying to convey? What is the thing that they are trying to convey? 8-year female child, and you know the answer is fibrous dysplasia. So, if at all I want to elaborate on this question, what would be another word that I would have put in this? This is a bone tumor which is predominant in female, and 8-year, why they have to mention this 8-year is because they are looking for the can you able to correlate it with one of the triad of McCune-Albright syndrome, which is precocious puberty. Precocious puberty. Am I clear? So 8-year female child. So from that they are looking for precocious puberty. And then they are saying thigh deformity X-ray is shown below. Multiple hyperpigmented spot. What kind of hyperpigmented spots that you will see in fibrous dysplasia or in McCune-Albright syndrome? Cephalo spot. So if you are seeing cephalo spot, whether it is with a rough margin or with a smooth margin. Rough margin, we have given even the Google map in our book, Google map of two places. One is California and another is Maine. Okay, how California is smooth and how Maine is rough, we would have explained it during our class. Is this having a rough margin or a smooth margin? Rough margin. Kanimoli, you got it wrong. This McCune-Albright syndrome, Kanimoli, let me explain it for you. Okay, McCune-Albright syndrome, the first word starts with M. So the coast of appearance in the coast of cephalo spot is coast of main appearance. Coast of main appearance. Kanimoli, are you getting this? Coast of main appearance. Okay, not coast of California. So McCune-Albright syndrome, yum, and coast of main appearance, yum. Now try to rub the first letter yum. Up, dip, up, dip. Is it a rough surface or a smooth surface? Rough surface. Unlike neurofibromatosis, in which there is a coast of California, and if you rub the first letter California, C is smooth. Yes or no? Yes, so yum, rough. Yes, so it is rough margin. See, why I am telling all this is, if 1 year they have asked this question, fibrous dysplasia, like this, the next year the question will be slightly into it. Okay, or a different question from the same topic. That is how they take. Okay. We don't have big Monday to ask very different questions, man, even in orthopedics. Okay, so we will just go through the previous question papers, like the last 10-year question papers. We will take up the topics and then we will ask a different question from the same topic, or what the question that we know from the same topic, we will just frame it as a question paper, and hardly 7 or 8 questions are going to be from orthopedics. Okay, so in this we learned precocious puberty, this stuff. Then just a sec. Yeah, and coast of main appearance. Anything else you want to know in fibrous dysplasia? This is 1P, another is this P, that is pigmentation, and another is polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia. So it is a disease of 3 P's. P for pigmentation, P for polyostosis, P for precocious puberty. And the appearance is shepherd crook deformity. Guys, is my screen lagging now? No, right? Please respond. Ajay, Aaron, Nandini. Perfect. Now, this question. What is the diagnosis first? What is the diagnosis? The moment you are seeing an epiphyseal tumor, the moment you are seeing a tumor at this edge of the joint, okay, the diagnosis is GCT. GCT. There is another diagnosis, clear cell chondrosarcoma. Very, very rare for them to put it on examination for you. Very, very rare. If you are seeing a tumor here, then you can think of either an osteosarcoma or a GCT-like tumor on the metaphysis. Then you can think of an aneurysmal bone cyst. But when there is an epiphyseal tumor that they have given, it is a clear-cut GCT, GCT, GCT. And without learning GCT, if you are trying to enter examination hall, you are trying to enter the hall without hall ticket. Is that possible or amenable? No. So GCT is such an important tumor that you need to know. So answer this question and don't look for soap bubble appearance. Just look for whether it is an epiphyseal tumor, metaphyseal tumor. If it is epiphyseal and then extending to metaphyseal, then the answer is GCT. Okay, so tumor arises from the epiphyseal to the metaphyseal region. So it is epiphyseal-metaphyseal tumor, but it all originates from the epiphysis. Tumor has a distinct margin. Yes, it has a classical distinct margin. Yes, true. It is an eccentric lesion. It is not in the center. Yes, it is an eccentric lesion because it is an eccentric epiphyseal eggshell crackling tumor. Chemotherapy is the treatment of choice. No, chemotherapy has no role. Chemotherapy has no role. No role. Now, since we discussed about osteoclastoma, there are another potential question. Any distal radius tumor they asking you? Any distal radius tumor? What? These are all like an exam clues, man. Any distal radius picture, if they have displayed to you and asked for what it is, osteoclastoma or giant cell tumor. Ewing sarcoma, the question will not start like 30-year-old. The question will start if it is a Ewing sarcoma at 10-year, 15-year, something like that. Okay. Okay. And they will give like a feature of osteomyelitis. Fever, ESR elevated, CRP elevated, and the tumor will be in the diaphysis. Pycnodysostosis. Pycnodysostosis is not a tumor, it is a skeletal dystrophy. It is a skeletal dystrophy and it is again diaphyseal. It is again diaphyseal, and one feature of pycnodysostosis which was tested in the past was blue sclera. Blue sclera. The moment you hear the word blue sclera, what would your mind think? What would your mind think? Osteogenesis imperfecta. There was one time they have displayed a blue sclera picture, and then which of the following can give this appearance? Students were very happy. I know the answer. It's going to be osteogenesis imperfecta. But the word osteogenesis imperfecta was not in the option. But pycnodysostosis was in the option, and the answer was pycnodysostosis. It is a skeletal dystrophic condition affecting the diaphysis of bone and is associated with blue sclera. Okay. Yes. Guys, is the speed okay? You want me to increase the speed or decrease the speed or something? Please let me know. Diagnosis. So do I really, this was an asked image. This was an asked image. Do I need to give you even an option? GCT. Okay, this was again an asked previous year question. GCT. So I'm telling you, without knowing GCT, entering an exam hall is a crime. Diagnosis. Nandini. Yes. This is enchondroma. Yeah. How many enchondroma? Multiple enchondroma. Multiple enchondroma. What is the diagnosis? Olier's disease. So you should look for this word Olier's disease. But just think, if they are giving a clinical picture, a clinical hand, okay, a clinical hand, you should look for vascular ectasia in that hand. If it is just X-ray, they are expecting an answer Olier's or Mafushi. But if they are giving a clinical hand picture, whether you are seeing an ectasia or not, I am telling you, they are expecting the answer Mafushi. So when such multiple enchondroma is in your question paper, what you need to look is for the word Olier's and Mafushi. If you are having both in the question, both in the option, then you need to look for the word hemangioma in the question. If there is no mention of the word hemangioma, but if they have given a clinical picture, just close your eyes and answer Mafushi, because they are trying to check whether you know what is the difference between Olier's and Mafushi. Olier's is multiple enchondroma, but Mafushi is the same multiple enchondroma plus hemangioma. And it is 100% malignant. 100% malignant. Olier's is like close to 30% malignant, but Mafushi is 100% malignant. We covered a few MCQs here. The most common bone tumor, benign bone tumor of the hand, osteochondroma. If it is multiple, Olier's or Mafushi. If it is with hemangioma, it is Mafushi. And Mafushi is 100% malignant. Olier's is 30% malignant, and solitary single enchondroma is only less than 5% malignant. This was like a classical question tested multiple times. Can someone answer this question? The most specific test for carpal tunnel syndrome is Durkheim test. And if you have gone to the last 2 years question paper, they have asked a few questions from carpal tunnel syndrome. They have asked questions like this. They have asked a question, instead of telling the word carpal tunnel syndrome, they said like the person is having pins and needle sensation in the lateral two-third of the arm, hand. Lateral two-third hand numbness. Okay. Match the diagnosis with the test, and then they have given the option carpal tunnel Durkheim test. Okay. Which of the following is looking like a Durkheim test? Is this Durkheim test? Is this Durkheim test? Is this Durkheim test? Or this one is Durkheim test? Why I am giving the picture is because this year I am expecting some picture. 1 year they have test what is Durkheim test. Next year they have asked you to match the disease with the Durkheim test. And this year we don't know, they might ask a picture. That's why I'm asking. A is Durkheim test. B is Fallon's. Fallon. B is Fennel. Fallon. C is Tinel. D is 2-point discrimination. Okay. So as in the option I have given you. What is B plus C? What you are trying to say? Prasanna. By the word B, A is Durkheim test, B is Fallon test, C is Tinel test, D is 2-point discrimination test. Are you clear, Prasanna? Okay. Try to answer this question. No. No, Prasanna. Allen's test got nothing to do with carpal tunnel syndrome. Yes, bipartite. It looks like a fracture, but it is not actually a fracture. Okay. Bipartite patella. Bipartite patella, which means patella arising from two different ossification center didn't meet in the middle, is called as bipartite patella. It looks like a fracture, and 30% of them are bilateral. So if you are not sure whether it is a fracture or not, please take the x-ray of opposite side knee. So don't diagnose this as a fracture. This is bipartite patella, and 30% of it are bilateral. So you have to take an opposite knee to check whether it looks the same. And what is this view called as? What is this view? Skyline merchant view. That again is a question. Okay, skyline merchant view. And what if the patella in this view is here? Instead of center, the patella has moved this way. What is the diagnosis? If it is a fracture, fracture. If it is a line alone, bipartite. Why I'm asking is, this image was given for a long time. Yes, it is patellar instability. Yes, it is patellar instability. If the patella has moved this way, this is the lateral femoral condyle. The one up like a hill, that is the lateral femoral condyle. Okay, if the patella, instead of being in the center like that, if it has moved or shifted to the other side, then it is a patellar instability, and the sign is J sign. Excellent. Excellent. So why I'm telling you this? Because 1 year they have given you a skyline view. The next year they have given a patella fracture in a skyline view. The next year they have asked bipartite patella. So if they want to stick up with the skyline X-ray, then the only next question what they can ask you would be an unstable patella, and the sign would be J sign. If they are going by that order, then there would be a question on this, and then patellar instability and J sign. This is very common among young adolescent female. So if the question starts like 13-year female while playing athlete, sports activity, sustained a click feel in the knee joint, and then it reduced spontaneously, but having pain over the anterior aspect of the knee, then you have to think of that. And if they have given a lateral view, and if there is a, Osgood's lattice is another good diagnosis. Okay, think of all these words before answering those kind of questions. What is the diagnosis? What is the diagnosis? What splint is that? No. What splint is that? Cock-up splint. Cock-up splint. What kind of cock-up splint? Dynamic or static? Because a static cock-up splint is also there. That will come in the front. That has nothing to do with the back. It will come in the front, and then it will brace here. It is a dynamic cock-up splint. Why am I saying dynamic? Because I am seeing springs here. Rubber bands, springs, and these fingers are hanged or held there in a pulley. So with this help of a finger and pulley, you can flex, and the rubber band will help you to extend. So this allows finger motion. So this is called as a dynamic cock-up splint, used for wrist drop, because the rubber band is just replacing extensor muscle. Extensor muscle. Now tell me, which of the nerves are supplying the extensor of the hand? Radial nerve. So the answer is radial nerve palsy. If at all, if there is an ulnar nerve palsy, what kind of splint will you use? Knuckle bender splint. Excellent. Answer. Answer is proximal third. Just assume this is distal radius, distal radius. This is the trichotrum bone. Trichotrum. So you are seeing scaphoid. So this is the distal part of the scaphoid. This is the proximal part of the scaphoid. Yes? Yes? And just assume if there is a distal most fracture, if there is a distal pole fracture, sorry, if there is a distal pole fracture, that is the distal pole, will there be any big avascular necrosis? No, there will be blood flow from here, there will be blood flow from here. Some or other one will supply. Okay. Some or other one will supply because the flow, there will be supply from here, supply from here. Okay. But if there is a waist fracture, the below the waist, there is only one blood vessel which is supplying. So the possibility of that enriched vascular anastomosis is not there in waist level. And that is the most common level of scaphoid fracture. Okay. But at least there is a chance for some vascularity from here, unless the fracture just wants to split in the middle of the zone of avascularization, then there is a chance of AVN. But otherwise, at least there is a little chance from supply here and also from here. But just think, if it is a proximal pole here, there is no too much of branch, just one branch will go there and that branch is gone. So that part is having highest chance to go for AVN. So distal part is having lowest chance. Middle third is the most common chance. Most common chance, in a sense, most common fracture of scaphoid is a middle third. So which fracture of scaphoid is having highest chance? Answer is proximal. But what type of fracture scaphoid is most common? Middle third. Middle third. Are you getting the difference, guys? When B can be a potential answer and when C can be a potential answer, most common scaphoid fracture is B. But most highest chance of avascular necrosis is C. Clear? Yes? Say yes or no. If not understanding, say not understanding. Guys, okay. Painful arch syndrome. This picture is from our workbook. Thank you. This picture is from our workbook. Thank you, guys. Okay. Yes, yes, no. My friend here knows that. Sir, please write. Oh my God, it seems you guys are not making notes. I have to write notes. Nandini, you are suggesting me to write most common scaphoid fracture. Okay. Proximal third, highest chance. Highest chance for AVN. And which part? Proximal part. Oh, don't be sorry, girls. Come on, you don't need to feel sorry. No one knows who is who here. Okay. Never say sorry for things like this. Okay. Have fun. No one knows. Hey, come on. Okay. No offense. Didn't mean to offend you. Sorry. My apologies. Painful arch syndrome. Pain is felt during mid-abduction. Painful arch syndrome. Pain is felt during mid-abduction. This picture is from is in our workbook. Okay. There won't be any pain here. There will be a pain here to here. and then there will be no pain. This is called as a painful arc syndrome, usually from 60 to 120 degree. Okay, and I'm telling you, if they are expecting the word rotator cuff tear, if they are expecting the answer rotator cuff tear, they will give this rotator cuff tendinitis, impingement. Then they will, without mentioning painful arc syndrome, they will just say mid-abduction pain is felt. And that too, especially when the arm is bringing down, when a person is bringing down their arm. It will be there while lifting, but it will also be there while bringing the arm down. And bringing the arm down, the pain would be more than the pain what the person had suffered while lifting. Okay, so that is a classical for rotator cuff tendinitis and impingement. If you are in my clinic, I will demonstrate it in like 20 patients every day. Okay, classical rotator cuff tendinitis and impingement pain, bringing very painful. And if instead of this question in the shoulder, if they want to ask something new, then they will ask about frozen shoulder. In frozen shoulder, abduction and internal rotation is most commonly affected. But if they ask you, see, this is the most common or most earliest. But while describing the question, they will say a person, all range of movements are painful, and when try to do external rotation, 0 degree or very limited external rotation, that is a word. Although the most commonly affected movement is abduction and internal rotation, invariably in clinical setup, an examiner would always assess external rotation to make this diagnosis of frozen shoulder. So invariably your question will have that word, reduced external rotation. Okay, but as according to Campbell, the earliest movements to be affected in frozen shoulder are abduction and internal rotation. Clear? Since they have asked the painful arc syndrome, then the next another topic around this region is a frozen shoulder. And shoulder dislocations are like Sethu Potanje topics that it's literally buried. So many times it has been asked. Okay, if you are not reading shoulder dislocation, you are making a grave mistake. And this is a very interesting question asked, and even in some online platforms, the answers are wrong. Okay, especially in the most famous online platform, the answer was wrong actually. See, everyone is answering B for this question. Answer is wrong. What is perilunate dislocation and what is lunate dislocation? Guys, can you see lunate is out? How will I name this condition? Lunate is out. This is radius. These are other carpals. And lunate alone is out. How should I name that? That is lunate dislocation. Now, this is radius and lunate, the moon-shaped bone, is still in position with radius, but the rest of the carpals are dislocated. Then how should I name that? That is perilunate. Which means the capitate bone is not maintaining the alignment with the radius while lunate does. That is perilunate dislocation. Now answer this question. If all are in same plane, then it is not a dislocation. If radius, scaphoid, capitate are in alignment, but lunate alone is out of plane, then it is lunate dislocation. Lower radius, scaphoid, lunate is in alignment, but capitate alone is out of plane, then it is perilunate. Both lunate and capitate are out of plane. It's complete wrist dislocation. Complete wrist dislocation. Okay, so the answer is C. Okay, for how many of you this image is new? How many of you have seen this image for first time in your life? Why I have displayed this X-ray is because they have asked this question once. So the next year, if they want to make a difficult question out of this, yes. See, for I think literally for everyone, it is a new images. Okay, everyone is saying it's myself, it's new to me. Okay, so why am I saying this is because 1 year they have asked a question on lunate. The next year they may easily put an X-ray and ask what kind of dislocation is this. Then only they know that you have read the previous year topic, not just glanced it out. There has to be a difference from a people who studied previous year questions and a person who just looked the question, answer, question, answer, question, answer. So many people ask, Kathir, you always stress on previous year question paper, but not many questions are asked. No, no, no. I'm telling previous year topics, not previous year question paper. Answer. The recurrent inflammatory, all the TNF. See, what is the treatment of rheumatoid arthritis? The treatment for rheumatoid arthritis are DMARDs. And DMARDs are interleukin antagonist, TNF antagonist, yes or no? So all these chemokines are they synthesized by B cells or T cells or macrophages? All these macrophages are the bomb of chemical chemokines, right? Or the literal bomb. One macrophage, if it goes there, it's going to release everything and all the inflammation is going to set in. Okay, so if they ask, although you will see a B cell, T cell, every cell there in rheumatoid arthritis, if they ask you single cell which is responsible for this, then the answer would be macrophages. Since I have asked the rheumatoid question, let me just discuss the previous year rheumatoid topic. But what if there is a swan neck deformity here, but without a hyperextension here? Can you see there is a hyperextension here? This is swan neck deformity. This is swan neck deformity. In this, the problem is not here. The problem is actually a tendon rupture at this level. Okay. And all you need to look is this PIP joint. If there is a same swan neck with the PIP hyperextension, then the answer is swan neck. If there is no hyperextension, then the answer is mallet. So Hari Prasad, Silambarasan, SS, Kalaichelvi, Danish, Kanimoli, Ramya, Nandini, Ritu, Darshini, Arun, everyone, you all are right. Muga. No, Muga? Okay. I think Muga attending all my revision session. Next. Yeah. Answer is Cobb's angle. See guys, even if they are extending this line and then marking that line here also, that is Cobb's angle. Because of insufficient space, if you are drawing a perpendicular line to this, perpendicular line to that, and then creating an angle, that is also Cobb's angle. That is a basic 6th standard geometry. Okay. The two lines, the angle caused by the two lines would be equal to the angle caused by the lines perpendicularly drawn to it. They are complementary to each other, supplementary to each other. There was a law, yes or no, in geometry. So they can ask sometime here or they can ask a line here. In both the ways, it is Cobb's angle. By the way, where is Bowler's angle. Where is Bowler angle? Bowler angle is related to which fracture? Excellent. Excellent. Calcaneum. Bowler angle and critical angle of Gisane. Bowler angle and Gisane angle. They both are in calcaneum. Bowman angle. Very, very commonly tested topic as well. Bowman angle. Bowman angle. Oh, supracondylar. Yes. Perfect. Supracondyle of humerus fracture is called as Bowman angle. Bowman angle. Now answer this question. Let's talk another interesting ortho question. A 60-year-old postmenopausal, answer is alendronate or bisphosphonate. Okay, she is not a smoker, doesn't take alcohol. Which of the following should be the first line treatment of her? It is bisphosphonate. Always for osteoporosis, answer is bisphosphonate. But when will you not choose bisphosphonate? Okay, when will you not choose bisphosphonate? If the question says CKD, if the question says, okay, severe gastric ulcer, then don't use the answer alendronate, because what this time they will do is they will frame the same question. Students will go and answer alendronate, but they will say CKD in the question somewhere at the end. A 60-year-old dialysis patient presented to OPD with a DEXA scan report of, see, they will not even mention CKD, they will just say dialysis patient. Okay, and literally rest of the question would beg you to answer bisphosphonate. Okay, don't go for that. In that case, the answer would be teriparatide. When you don't want to answer teriparatide, the same question would be a 60-year-old chemo patient, then you can never use teriparatide in a patient who is having a cancer, So you will never use. See how by changing one word, I am changing the answers. Okay. And instead of using the word, which of the following should be the first line of treatment? Instead of this, which of the following is anabolic to treat this condition? Then the answer is teriparatide. Okay. Teriparatide. Okay. Denosumab is, of course, another monoclonal antibody which can be used to treat the osteoporosis. Try to answer this question. There was a tabular column in my workbook. CA patient, what should be given, sir? If the CA patient with a normal kidney, I would still prefer bisphosphonate. Okay. Cheap, one injection, easy. But another option would be denosumab. GCT. What will you do for GCT? We have to actually do an extended curettage. So I am going to look for extended curettage in any other options. None of these options are extended curettage. So GCT I am matching with this. So A is going with 4. Which of the option is A4? Yes, that's all. I don't even need to see other options. How many of you did all 4 now? Match the following. If you know even one thing perfect, and that is the only option there, then you don't even need. Did one look, Ramya? Ramya is smart. But let me discuss. Osteoid osteoma. What will you do? Osteoid osteoma, the recent invention is radio frequency ablation. Previously, we were using burr holes. Simple bone cyst, intralesional steroid can help in a simple bone cyst. Osteosarcoma. Will you do wide excision alone for osteosarcoma? Because in wide excision, even if you are removing a wide excision, just assume if there is a skip lesion, that skip lesion is not going to be removed. That skip lesion is not going to be removed. This is from my workbook. Okay, simple bone cyst you can do. Intralesional steroid. Marginal you can do. If there is a marginal, that will still allow skip lesion and satellite lesion or extended curettage, which you can be doing in ABC, aneurysmal bone cyst, chondroblastoma, giant cell tumor, enchondroma. In all these conditions, you will do an extended curettage. This is a tabular column from our workbook in page number 109. But wide local excision you will do for osteosarcoma. But remember, that may still leave a skip lesion. That will be a question. That may still leave a skip lesion. If you don't want to leave even a skip lesion, then you have to do what is called as a radical excision. Radical excision in osteosarcoma of distal femur after doing a wide local excision. What would be your replacement option? Answer is custom megaprosthesis. Am I making sense? In marginal lesion, you will not be even removing satellite tumor. You will not be removing a skip tumor. In wide local excision, you will remove the satellite tumor, but not the skip tumor. Guys, are you understanding? But in radical, you will remove both satellite and skip lesion. Only you will not be removing a distal metastasis. So what is the difference between intralesional, marginal, wide local, radical, and what is the treatment for each of tumor? You must be knowing from that tabular column in our class. This is another classically tested. See, open fracture compartment syndromes are very commonly tested questions for you guys. Can someone tell me what is this? Yes. There is pins into femur and there is pins into tibia. So there are pins in two bones spanning a knee joint. So this is what called as joint spanning X-fix. Okay. This is Elizaro. Now tell me, among this, which is increasing, has the highest stability? This is having highest stability, which means Elizaro is having highest stability. And the question asked is increasing order of stability, which means highest stability should be in the last. So either B is option or C is answer. Okay. Next, uniplanar or biplanar, which has to be stable? Biplanar has to be stable. If you don't know what is biplanar, I will put one rod from anteroposterior and one pin from mediolateral. So the two pins will go perpendicular to each other. So that is what called as biplanar. One pin from the center straight and another from the side. That is biplanar. Biplanar frames. Okay, this is uniplanar, but two rods. Uniplanar, but with two rods. So maybe that is slightly better stable than a uniplanar with one rod. So the answer would be uniplanar with one rod is the least stable. Uniplanar with two rods is slightly better stable. Biplanar is much better. and Elizaro is the best. Okay, clear? And this was an asked question actually. This was an asked question. Okay, joint spanning knee fixator, or they can ask this here as proximal tibia fracture with gross comminution and possible compartment syndrome or open fracture. How would you stabilize it immediately? Then the answer should be spanning the knee joint. I'll put an external fixator. This was another question asked. The answer is from the first page of our workbook. First page of our workbook was having the answer for this question. This gentleman, his name is Bowler. Okay, father of trauma surgery actually. So answer this question. So the people are Arun and Sabri. Guys, you happy mentioning your name, right? Anyway, you texted to everyone, which means you have to be happy. Bowler stirrup, Steinman pin, and bowler frame. That's what you said, right? By answering the word A. And Shweta, don't worry. No one know who is Shweta. Okay. So if you say A, Thomas Splint, do you need Thomas Splint for this construct? No. So definitely A is ruled out. D is ruled out. It is either B or C. Now say, who's that? How many of you are saying C? Okay, Aaron. Aaron, man, will you get offended if I like use your name and all? Yeah. See, Aaron, you have thought denampin because I have given denampin in my notes. But remember, what is the difference between a denampin and a Steinman pin? Denampin is a centrally threaded Steinman pin. That's all. And that is used for cancellous bone like calcaneal. Steinman pin is used for cortical bone. Look into the question. Tibial traction. So whether you use denampin or Steinman pin, that is what is being tested between these two options. Denampin I will use for calcaneum. Steinman pin I will use for tibial traction. And the last 2 years back, they have given this tibial traction. So the answer is 2, 3, and 5. But if they use calcaneal traction, and if they changed the question from fracture shaft of femur to fracture distal tibia or shaft tibia, then the answer will become C. Did you understand, Aaron? Yes, because when there is a tibial fracture, you will go for bones below that. So calcaneum. For calcaneum, the answer is denampin. Why am I saying is, there may be a repetition, but people would think it will be an exact repetition, but it is not exact repetition. They will change just 1 or 2 words and then make a different answer. Clear? Clear? Is this discussion helpful? Yes. Thank you, Satya. Thank you. Which of the following substance is used for bone formation in patients with non-union? Thank you, Sankamil. Thank you, Shweta. Excellent. Bone formation. Do you remember in my class, how many of you are saying C? All the big guns are saying C. Come on, guys. Calcium phosphate and calcium sulfate are just going to be an osteoconductive material. They cannot create a bone. PMMA, which is the content of a bone cement. Bone cement or hard lens. Do you think by putting a cement, it is going to create a new bone there? You are just going to fill that space, and that is not even a glue. The cement is not even a glue. It is just a grout, just a filler. It is not even having an osteoconductive property. So bone cement is not having an osteoconductive property, not having osteoinductive property, not having osteogenesis property. Calcium phosphate is having at least osteoconductive property, but no inductive or genetic property. But the question asked is bone formation. So it means it should have at least induction or genesis property. Among this option, only D is having osteoinduction property. Where was this discussed? In our notes. In our notes, I think page number 5, if I am not wrong. This was tested in INISET, osteoinductive property, bone morphogenic protein, transformation growth factor, insulin-like growth factor, and platelet-rich plasma. These days are used for bone healing. All these are having osteoinductive property. Still, they are not osteogenic property. Only an autograft is having an osteogenic property. Do you remember me telling all that during the class? Osteogenesis, osteoconduction, osteoinduction. I think if not, you should look into page number 11. If not, in our workbook. Okay. How many of you would have answered C? Let me just check. All tokens, people who were answering right from the beginning were making wrong answers for this simple question. Guys, now it's all, is it all clear now? Guys, done? Shall we go to the next question? Spine straightening surgery. Screws are fixed to which part of the vertebra? Whatever the surgery, if you want to put a screw into vertebra, it will go in only one part, pedicle. Because if not pedicle, if I am going to put into laminae, it will break the, this is the laminae screw, right? If I am putting a screw in the laminae, it will go here. Only if I put a screw in the pedicle, it will go in this direction. Yes or no? And how would a pedicle look? This is from our class, I think page number 25 or 23. Okay. Pedicle would look like an eye in an X-ray. So C-arm, when a patient is lying down, you take a shot in a PA view and you will see the eye, and in the eye, you will put the screw directing towards the body, and even in the class I have described the direction of screw in the pedicle like that. Yes, pedicle. Among the following drug which promotes bone formation, this was already discussed, teriparatide. That is the only true analog, page number 11. Only true analog, page number 11. Child suffering from chronic osteomyelitis. These kind of regular repeats question you can expect in any NEET examination. What is the structure? Sequestrum. In our class, I would have described what is sequestrum. The dead bone is sequestrum, and the surrounding new bone is involucrum, and the hole in the sequestrum, in the involucrum is called a cloaca. And they have this habit of asking ring sequestrum by putting a picture. You have seen Ilizaro, right? Ilizaro. You have seen external fixator. In all that, you are putting rods into the bone. Those tiny little rods creating a sequestrum around their insertion point is called as ring sequestrum. That is seen in pin site of external fixator. That can be another potential question that was asked as a question several times. Other types of sequestrum. This is from our exact class notes, guys. Dead white Sclerotic bone is sequestrum, and it is dead white. That is very important. Next it will look more white and sclerotic. Ring sequestrum is external fixator. Tubular sequestrum is sickle cell anemia. Coke and raised strain sequestrum is TB. Feathery sequestrum is syphilis. Colored sequestrum is fungus. Annular sequestrum is amputation. Large diaphyseal sequestrum, salmonella. Large diaphyseal sequestrum, salmonella. Because this was tested one time, like they have given a, they have given a bone histopath, and then said, this part is from the diaphyseal things and things like that. And then from the histopath, you can find that was a dead bone. Okay. And then they asked what could be the potential organism. The answer is salmonella, because diaphyseal osteomyelitis can happen very commonly among sickle cell anemia patient, and the organism causing it is usually salmonella. This question. I think it is last year. This question was asked, and they have asked you 2 questions from ankylosing spondylitis. 2 questions from ankylosing spondylitis. Answer is ankylosing spondylitis, because they have used this word. By this, what they mean? Backache, and they have given X-ray of sacroiliac joint. See, bamboo spine, etc., is good. Dagger sign, I can see a dagger here. I couldn't see a bamboo spine, because can you see a bamboo spine? I don't think so. Radiological feature of ankylosing spondylitis, Dr. Kathir. Type in YouTube. Okay, you will see a classical bamboo spine. Type in YouTube, you will see a classical bamboo spine. Like 5 minutes video, man, you will see all the signs of ankylosing spondylitis there. Okay, even if you go to your workbook in the topic ankylosing spondylitis, there will be a QR code. Just scan it. It will take you to that video. Okay, that is a classical bamboo spine. Here I am seeing a dagger maybe, and I am seeing a fusion of the sacroiliac joint. Okay, without a fusion of sacroiliac joint, never diagnose ankylosing spondylitis. Okay, so this, and also literally the question starts with like 26-year-old male, a male predominant early age disease, a person in his 3rd decade, male. Literally the question is begging for the answer ankylosing spondylitis, because rheumatoid is a female predominant disease in their 30s. Clear? Why am I saying multiple long bone fracture? I received a patient recently, like 3 days back. Intrauterine scan shows multiple long bone fracture. Answer is osteogenesis imperfecta. Okay. Loose clear. Pattern of pot spine. The blood vessel always comes like this, and by embryology will go to the lower part of the upper vertebra and upper part of the lower vertebra. And whenever there is an infection comes, it goes through the blood flow. So it goes and deposits in 2 continuous vertebra. So the most common type is paradiscal type. And when will you operate when there is such collapse? You will operate whenever there is a neurological complication, not without a neurological complication. So the answer is A. Cold abscess without a neurological complication, I will not operate. But with the neurological complication, when the diagnosis is doubtful, if it is not responding to the drug, if the person is having cauda equina syndrome, which is emergency, which is an emergency, in these cases, you have to operate. You have to operate. This is the same question, pedicle screw. Just for the sake of better images, I have used this question again. Okay. If I put lamina, can you see how it is going to damage the spinal cord? Only if I use in pedicle, it will go through the whole bone. If it is a lamina or spinous process or the facet joint, if it is a facet joint, just assume if it is a facet joint, the screw is, then it will go into the disc rather than into the bone. Yes? A person is having an abduction and external rotation 22, history of RTA. I won't expect an intertrochanteric fracture in a 22-year-old person. Okay. And the classical abduction and external rotation with gross, can you see here? Anterior dislocation. The classical abduction and external rotation. In intertrochanteric fracture, you will have some abduction, but that is not as bad as an abduction in an anterior dislocation. So for this anterior dislocation, if the question says 72-year-old female and abduction, external rotation and shortening with crepitus, then the answer would become an intertrochanteric fracture. Answer would become an intertrochanteric fracture. Okay, in a young individual, less chance for an intertrochanteric fracture. Oh, yes, 72 age. Yes, C or D. Both will be the option, answer. Both can be an answer in a 72-year-old female, intertrochanteric or fracture neck of female. Yes, you are right. Yes. I didn't see the D option at all. But if they ask you between C and D, which is having more abduction and more external rotation deformity, then the answer is around IT. Then the answer is IT. Excellent. Answer this question. Okay, my next step would be whenever there is a dislocation, it is an emergency. So once I confirmed the dislocation with an X-ray, then I will reduce. Now, if I had done this and just assume the sentence A is already given here, okay, and then they are asking what is the next step of management, what will you do? I have done A. Now I'm going to do the next step. After reducing a hip reduction, what will you do? I will do B. I will take CT pelvis because I have reduced. But as you may know, there is a classification called as Pipkin classification, in which they deal with the femoral head fracture, and the Thompson-Epstein classification, in which they deal with the acetabular fracture or femoral head fracture associated with the hip dislocation. So a hip dislocation may not be a true hip dislocation. There may be an associated fracture. You don't have enough time to do this kind of assessment without reducing the patient. So you will take an X-ray and reduce. But after reduction, invariably do a CT scan, make sure the acetabulum is normal, femoral head is normal. Why? Because if you are not doing this, there is a very high chance of hip arthritis or avascular necrosis. So 3 years back, if they have asked this question, this year they may just put option A into the question and then frame a different option. Guys, what am I doing here? Am I just repeating the previous year questions? You can get that from any online platform. Are we just doing that? No. How an examiner would think. I still remember my first year Viva session, in which before going to the session, my physiology ma'am asked, Kathir, what is a basic question? My physiology ma'am asked this question. Can anyone answer? What is a basic question? Define basic question. My physiology ma'am said this definition to me. The question is considered basic if the examiner knows the answer and the candidate doesn't know the answer. A question to which an examiner knows the answer, but the candidate doesn't know the answer, they will frame it as basic question. Don't you know this basic? That's what they would say. So, answering a Viva is not about reading your books. Answering the Viva is about reading the examiner mindset. So whenever you are revising previous year question, this is how I want you guys to approach. Are you guys understanding what I'm trying to do? Okay, so when you are seeing a previous year question, just read more, but try to frame multiple questions from the same topic by just juggling new words into the questions. Okay, that is very, very important. Meniscus, this is another neat question. Which zone heals faster? Whichever zone which is having highest blood supply will heal faster. Highest blood supply zone is red zone. Which is the nerve damaged in shoulder dislocation? Axillary nerve. In proximal humerus fracture, axillary nerve. Subcoracoid, axillary nerve. Subglenoid, axillary nerve. And if they ask which muscle is compromised, deltoid. Which and what other muscle? Teres. Teres minor, yes, teres minor. Which part sensation is lost? The upper lateral aspect of the arm, regiment batch. Regiment batch. All these can be questioned. Okay, Coley's fracture. Now this question they are trying to check whether you know Coley's fracture is an intra-articular fracture or an extra-articular fracture. As simple as that. Because Barton is an intra-articular fracture. Boxer is not a distal radius fracture at all. It is a metacarpal fracture. So if they have made Coley's fracture as an option, it would have become a very easy question. By giving the word intra or extra, they are just creating little confusion there. The answer is extra-articular because you know Coley's fracture is extra-articular. The moment the fracture line goes into the joint, it will become a Barton fracture. And if that fragment is in the dorsal, then it is a dorsal Barton. If that fragment is in the volar, it is called as a volar Barton. Volar Barton or dorsal Barton. Clear? Yes. This is Coley's reduction. How would you reduce a Coley's fracture? Always you will do the traction first. Definitely not POP after that. So option A is wrong. I will do traction, palmar flexion, ulnar deviation. B is the answer. Okay. Please take screenshot or otherwise don't worry. I will give you this PowerPoint or PDF. Now this is the same question we discussed. This question, what fracture are we dealing with? What fracture are we dealing with? Can you see a fishtail there? That's the classical fishtail, distal end of humerus. It is a supracondylar fracture. This was asked. So what I did is, next year they will deal crescent sign is seen in fracture of, or they will give you this image and ask what sign. Can you see a small crescent? Yes. Yes, that is supracondylar. I know you know this, guys. Pat sign. I know you know this. This was like multiple time tested. I know you know this. Yes, this is fishtail. This is crescent. For how many of you, this is the first time you are seeing crescent sign in supracondylar fracture? For how many of you, this is the first time seeing a crescent sign? Just put up your hand. See? See? There are at least like in a class of 110, there are at least 10 new people. I just assume only for 10 people it is new. What is this fracture? Since we discussed supracondylar fracture, another thing is a lateral condyle. How you know this is the lateral condyle, not the medial condyle? This is the radius bone. Radius bone is the lateral bone. So this is the lateral condyle fracture. And what is the most common complication? No. Tardive ulnar palsy is the last complication and a late complication. The question asked was most common complication. I didn't even give an option. Valgus deformity due to non-union. Non-union causing cubitus valgus. Not malunion causing cubitus varus. Non-union causing cubitus valgus is more common. Hence, this fracture lateral condyle of humerus is called as fracture of necessitance, which means you have to operate. You have to operate. And these kind of x-rays they will put under this like multiple time tested. If there is no genu varum and if the edges are very clearly marked with white line, then the answer is curvy. If the edges are so blurred like a brush as in here, can you see the difference between this edge and that edge? Look into the inner side, okay, inner aspect of the knee joint. Can you see the difference between this edge and that edge? That edge is having all white. This edge is like a brush. I couldn't even demarcate the line. Yes, that is what called as fraying. Fraying. So that is rickets. This is scurvy. Scurvy. Something like osteoclastoma and giant cell tumor. One another topic which you don't want to mess around is compartment syndrome. Compartment syndrome. Without reading this topic, never even enter the hall. Okay. Whenever there is a passive extension painful, whenever there is a passive movements painful, then you have to think of compartment syndrome. Patient is telling having a past fracture and you have applied POP. Patient is telling pain more than the actual fracture. Then think of compartment. They have literally given you all the signs of compartment syndrome. Passive extension was painful. That is the most common feature and the most earliest feature as well. And then loss of sensation is the second feature. Pulse loss is the last feature. So this will be present invariably. So don't worry. Don't worry. That is the least reliable. Pulselessness is the least reliable. Pulselessness is the least reliable. Appears late in compartment syndrome. Pulselessness. Useless sign. Useless sign. Pain on passive stretch is the earliest sign. This is the earliest sign. Again, compartment syndrome. So I think I have discussed enough about compartment syndrome. And another question was counter force brace was used in. This is another neat question. This is the counter brace, guys. Counter brace is used for tennis elbow. Scoliosis screening test by bending the person. They have given this image. They have given this image and asked what disease is this used for? Scoliosis. Okay, so forward bending test. What is the name? Adam test. Why am I using a girl's picture? Because scoliosis is most common among women. Which age group? Adolescent. So done at school. So they are literally telling you female Adam test. And what are all the braces used for scoliosis? This was asked a question. Milwaukee brace. Then they may ask, what is this? Boston brace. What is this? Taylor's brace. Taylor brace. Taylor brace is usually used for fracture. Ash brace. Ash brace again used for fracture and degenerative diseases. Ash brace. Anterior spinal hyperextension, ASHE, anterior spinal hyperextension brace. Hyperextension brace, like that. Osteosarcoma, these are all classical questions. I don't want you guys to mess around, okay? They will literally beg you for answer. 10-year-old boy, metaphysis, which means close to distal femur or proximal tibia, they will give you, okay? So the answer is osteosarcoma, classical. They might give you this picture or this picture or this picture. Whatever it is, osteosarcoma. The typical sunburst appearance because of the periosteal reaction and a classical Codman triangle. Any of this word should ring a bell to osteosarcoma. These are all very common. Osteoclastoma, already discussed. Ankylosing spondylitis, which we were discussing. Diagnosis, CTEV. When will you start a treatment in CTEV? As early as possible. In this option, in just few days. As early as possible. If I am saying it on day 2, yes, I will do. And I'm pretty sure usually pediatrician or obstetrician will not call you on the day of delivery. They will never call orthopedician on the day of delivery. Even if they call, we won't go. That is different. Okay. Second day when the baby is all clean, we will go and put some POP and then come out, right? Yes. So in few days. And how would you correct this? First, you will correct the. Okay. So how would you correct the scale? What are all the feature? What are all the feature of CTEV? That is what the asked question. Yeah, now answer this question. Yeah, you all know cave, but answer this question. Will there be equinus? Yes. So everything is having equinus. Answer is cavus, adduction and inversion. Okay. Cavus, adduction, inversion and equinus. Inversion. Can you see the inversion? Forefoot adduction and inversion. Answer. All asked question was just a quick revision. What neat concept we have discussed? These are all mere question and answers. whenever there is an open fracture, will you do a close reduction? Will you do an internal fixation? Will you do a splinting? Will you give an antibiotic coverage? Invariably, you have which of the following is not required? Invariably, you need antibiotic coverage. So, if the option has 4 in it, then it is ruled out. Okay. Will you do splinting? Yes, I will do splinting. So, I will do splinting. So, if it is having 3, it is ruled out. On an emergency basis, do you need an internal fixation in case of an open fracture? No. So, the answer is B. No, it is not needed. It is not needed. But can you do internal fixation? Yes. For this question, answer is B. But can you do internal fixation in an open fracture? Yes. If it is type 1, if it is type 2, but with little damage, Type 2, you can do. Type 1 and type 2, you can do bit of a internal fixation. You can try, but still the possibility of infection is more. Ring sequestrum, we discussed. Answer for this question? Yes. Answer for this question? Rickets. And let me tell you, by giving this word, what are they indicating? Will you do surgery for rickets? Will you do surgery for rickets? Yes, but only after the alkaline phosphatase is normal. Yes, exactly, yes, exactly. By looking into that word ALP, that should remind you this word. Will you do surgery for rickets? Yes, to correct the deformity, I can do surgery, but only after alkaline phosphatase coming back to normal. Answer. In osteoporosis is never a diagnosis of chemistry or chemicals. You don't need to order vitamin D and calcium to diagnose osteoporosis, because by checking calcium and vitamin D, you are looking for the disease osteomalacia, but not osteoporosis. What is osteoporosis? The entire bone matrix has shrunken. But what is osteomalacia? The proportion of mineralized and unmineralized bone has altered, but not the bone mass. Bone mass is intact in osteomalacia, but bone mass is reduced in osteoporosis. Clear? Clear. So, if we are going to supply vitamin D and calcium to these people, this people is just going to achieve this, but will never become that. In order to achieve that, you need bisphosphonates or teriparatide or denosumab. How many of you in your practice has managed osteoporosis with just calcium and vitamin D as of now? Please raise your hand. Or during your internship has managed osteoporosis with just vitamin D and calcium? Please raise your hand. But please remember, if you do blood test, everything will look normal, guys. Okay. This is what they are checking. You will firmly believe that you know the management of osteoporosis, but firmly it is wrong. Okay. Whatever you are giving, the vitamin D and calcium is going to correct only the osteomalacia component of an elderly individual, but not osteoporosis. In order to correct the osteoporosis, you have to give them either a bisphosphonates or a teriparatide or a denosumab. Neuropraxia, this and all easy. Yeah. Benediction sign. Benediction sign. Seen in which nerve? Median nerve. Excellent. So there will be at least one question from any of this sign. They will give questions like this and then ask, or they will ask question like this and then ask which muscle is checked and which nerve is checked. The muscle checked is ADRPLEXUS and the test name is card or book test. And the nerve checked is ulnar nerve. They can ask you, like, you know, the ulnar nerve, median nerve and radial nerve is having quite a lot of these kind of images, and they can check any of that. Osteoclastoma, compartment syndrome, this stuff. These three are key. These three are key nerve signs. Yeah, so these kind of nerve questions, pretty much the class is over. So don't worry. Okay. So that was like a last question that I wanted to discuss. So it's slide 63 of 63. So pretty much I have discussed everything from the last previous year tested questions and the topics. Do you have any doubts on these topics, guys? Please write it down. Answer is inability to attack the fingers. Love you guys. Love you. I appreciate that big message. Thanks. I will share the PDF. I will share the PDF 100%. Anything? Thanks for that amazing feedback though. Thank you. So guys, please let me know if you have any issues with orthopedic questions anytime. I'm happy to clarify it anytime. Okay. I'm jobless, so don't worry. Okay. See you guys. Enjoy the Sunday. Have some nice biryani. Thank you, SS. Thank you. Have a nice biryani and enjoy the rest of your day. Bye-bye. Good day. Good luck.